My name is Clara Wagner, and I want to talk about the review that I made about humanized antibodies versus current therapies for the clostridium difficile infection recurrence. Right. Clostridium difficile is an anaerobic, gram-negative, spore-forming bacteria that contains two kinds of toxins, the toxin A and the toxin B. The toxin A produces a fluid secretion and a high that increase the permeability of the cell, whilst the toxin B intensified the colonic inflammation. The transmission, the symptoms of after somebody is infected will be by the fecal oral route. So it will have strong diarrhea and colitis. Right. What are the risk factors? Well, there are a few factors such as environmental type. So those are the ones that due to the spores. If you are in a hospital and there is an infection, obviously the spores are going to spread and the risk of get contagious, it will be high. Another factor is the individual circumstances of the patient. For example, if they are more than or older than 60 years old, it's believed that it has more tendency to get the infection quicker. There is not much in this, or in the past, it was believed that it wouldn't affect children and pregnant women, but the research has been changed, and lately there has been demonstrated that that population has been increasing. How to diagnostic? The diagnostic basically is culture, toxigenic CD in feces, immunoacid, and nucleic acid tests. Unfortunately, the nucleic acid tests, they don't have standardizations, and it's very difficult to create a data when all the standards are completely different to one kid to another. Epidemiology. Clostridium difficile has become a really big concern for many countries, like USA, Europe, and in Australia it's become a big problem. Right, the main problem that we have with Clostridium difficile is the recurrences. When a person comes, get hospitalized, this is a small graph to show you pretty much where does it go. The person acquire the Clostridium difficile infection, get antimicrobial, all sorted, but then somebody will be get a symptomatic colonization, and another one will be symptomatic. That is when it's a failure of the first treatment. What has been done? Right. The normal ones, so the ones that have been using or in the last 30 years are metronidazole and vancomycin. Metronidazole inhibit the nucleic acid integration, so it doesn't allow the protein synthesis, so it blocks it. Whilst vancomycin, that is another one that is widely used, inhibit the glycopeptide polymerization that is essential for the cross-linking. The problem with the metronidazole is that it's been associated with accumulated neurotoxicity, so it's not recommended beyond the first infection. So normally it's first infection, neutrodesin, and then second is the vancomycin. There is another one that is being used lately that is fidaxomicin, is bactericida. This attack the Clostridium difficile. What it does is control the expansion, reduce in vivo and in vitro functions. So it's been quite good, but still it's not it hasn't been widely used. So there is no data about that one as much as it could be to confirm that that is the way to go. There is another one like the biotherapies. These ones are the transplantation of flora microbiotica. The problem is that also can create opportunity for increase the clostidium difficile when those bacteria that protect against them are being killed. There are others, also the oral ones, but they haven't been proved scientifically, so there is no a significance with the oral ones so far. Now, the immunology therapies, some the immunology has been basic, has been focused in the toxin A. But what is being demonstrated is that the toxin B is imperative part of the infection. So this is not attacking the problem completely. So what is happening nowadays is there is two new ones, monoclonals that appear, and these monoclonals are the actosumab and the beslotuzumab. As I said, both of them are monoclonal. The idea is that, well, they use it in a trial called Modify 1 and Modify 2. In this trial, they have three groups. One group with beslotuzumab and another one with actosumab. And the third one was just with placebo. The conclusion of this trial, there was a scientific significance with the beslotuzumab, reducing the recurrence in the patients. While it wasn't happening exactly the same with the actosumab. So, as an only one individually, if they go alone, they are not proving much efficiency. So the beslotuzumab seems to be the way to go. So they're still finishing the trial. They're trying to go ahead with that one, and also trying to combine it with the more traditional antibacterial like the vancomycin in combination with beltosumab, and it seems that it's going in a good path. The problem with this is we don't know where we have to evaluate now two important things. First of all, because the comparison with data is not standardized, it's very difficult to conclude things and determine what scientifically is going to be doable. So that's one of the main problems with all these therapies. With beslotuzumab especially, the problem is if it's cost effective, because it's a quite expensive antibacterial one. So that is what it needs to be determined, if it's the cost effective as it should be, and if it's this the way to go. We can't forget that there are trials for vaccine too. So at the moment there is nothing that is being confirmed that this is the way to go for the recurrence. So we just have to wait and see what comes into the future, into the near future. Apparently the beslotuzumab are very close, but I couldn't find in my research any confirmation that they have been go through. Thank you very much for listening.